Today, I want to focus on what a day for our clients might look like when they're very complex on BIPAP with cerebral palsy. What does that day look like, and can they still have community access? Because that's a question we get quite frequently from our clients or potential clients, and I want to do a deep dive there today. My name is Patrick Hutzel from intensivecareathome.com, and today I just basically want to read out one of the nursing reports from one of our nurses who's working with a complex client with cerebral palsy on BIPAP. I'm obviously not going to mention names, but it gives you an idea because, especially with NDIS, there's a lot of very complex cerebral palsy clients out there that need help. So that's the beginning of the shift. This is a day shift, obviously. Client is asleep with BIPAP machine on, 8:30 and 9 a.m. medications and feeds given. BIPAP off at 9:30. Oxygen saturation is 97% on room air. Oral care attended. Client mobilized from bed to chair by the mother, who carried the client into the mobility power chair. The client lifted in chair by the nurse, while the mother attended to hip alignment in the chair. Simulation given via feeding tube at 10 a.m. Went to the neighboring home care center with one of our other RNs and returned home at 1 p.m. Client is engaging and is alert, mostly stimulated on shift. 2 neuro drops today lasted less than 10 seconds each before the client recovered on her own. Client is supporting her own airway. At present, it's patent with oxygen saturation on 97% on room air, with audible secretions to be suctioned out, no increased work of breathing. Thick, pale yellow secretions removed. Hypertonic normal saline nebulizer given. Remains warm and well perfused. Bowels not open. Feeds given as charted. PEJ skin looks healthy. PEJ means a jejunostomy tube. Nil leakage observed in the morning, dry and intact. Hourly 125 mL water flushes given. Large wet pad. Urine is NAD. Small pressure injury is noted to sacrum, not blanching as it remains pink while surrounding skin is blanching. Next. NPA and OPA suctioning required every 30 to 60 minutes for thick, clear, creamy secretions. So NPA is a nasopharyngeal airway and OPA is an oropharyngeal airway. Basically, it's like a plastic tube that goes either into the mouth or into the nose that guides a suction catheter to do some deep suctioning in the lungs. Now, that can be very uncomfortable, but it is also extremely effective most of the time. Quite a few of our clients require deep suctioning, and it is a skill that requires a critical care nurse, not just even a general registered nurse. Hypertonic saline and aztreonam nebs were given. Heart rate and oxygen saturation remained within normal range during the afternoon nap back on BIPAP. Flickering was noted with 11 witnessed atonic drop seizures. The PEG tube is leaking mildly. Dressing was changed and pseudocream was applied to the overgranulating PEG skin, which remains unchanged. Client is tolerating feeds. Bowels open medium ×2, type 6. Large voids, ×3 with minimal vaginal discharge. The abdomen is soft but slightly distended bowel. Sounds are present. Stage 1 pressure injury to sacrum remains unchanged despite decreased chair time and massage. 1 centimeter above the sacrum, there is new skin redness, but it's blanching and is improving. The right axillary skin breakdown remains stagnant. Personal care attended. Feeds and flushes were given as charted. Client went for a walk around IKEA with staff and family. Client had increased tummy smacking and appeared cranky, which settled. Client had a good rest in the afternoon. Heart rate from 90 beats per minute down to 60. Potassium 2.5 millimoles. and KCl 30 millimoles administered, and calcium 2.81 millimole were administered. So you can see that with the report, there's a lot of work that goes into the day-to-day care for our clients, of course, especially when they're complex, when they have compromised airways, which is the case with this particular client. But, we can still take care of the client, and then they can still have community access as described in the report, and they can still have all their care needs met, regardless of whether they have community access or not. And we can give the same care to your family member if your family member needs help in similar situations. So with all of that said, with intensive care at home, we are currently sending our critical care nurses into the home 24 hours a day. Therefore, we are providing a genuine alternative to a long-term stay in intensive care for ventilation, tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, and tracheostomy care without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions, IV fluids, and IV antibiotics. We're also providing cough assist management at home, ventilation weaning at home. We're also providing central line, peak line, Hickman's line, as well as port management at home. We're also providing nasogastric tube and PEG tube management at home, as well as palliative care management at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That means we're also in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Intensive care at home costs between $2,500 to $3,000 per bed day. And we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. With intensive care at home, we're currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We're an NDIS approved service provider all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a provider have also received funding through public hospitals, private health funds, as well as departments of health. We are the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025. We have been achieving this high level of accreditation since 2012. No other provider in Australia has achieved this high level of accreditation in the community and has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, and that enables us to look after the highest acuity adults and children in the community in Australia safely. If you're at home already and you're watching this, or you're stuck in an ICU and you realize that you don't have the right level of support, I'll give you a very tangible and real-world example today how we can help. One of our first clients when we first got started over 10 years ago in 2012 was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, disability support workers cannot look after a critical care patient on a ventilator with a tracheostomy at home. That is dangerous, and it's negligent having support workers looking after a client at home on a ventilator with a tracheostomy. That is like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies, or is at very high risk of dying if they don't have a stable team of critical care nurses looking after them 24/7 at home. This is actually evidence-based in the community and is documented in our mechanical home ventilation guidelines that are evidence-based that you can find on our website at intensivecareathome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind would do that in a home care environment where there are fewer resources? So eventually, this client in the ICU that he was basically living in found out about us, and we were proving our concept with this ventilated and tracheostomy client very fast. When we worked with a ventilated and tracheostomy client, we sent him intensive care nurses 24 hours a day, and he never went back into ICU ever again when we were proving our concept there very fast. The insurance body saved half of the cost of paying for the intensive care bed, so it was a win-win situation all around. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it, which ties in with what I talked about just now. We have always successfully advocated for our clients, otherwise we would not be in business. The same is applicable and for those stuck in an ICU, similar to many of our cases. Please reach out to us. We'll make it happen for you as well. We can take you through the right steps. This is also why we are providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDI support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog below the video. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCotter. And if you're an NDI support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and how to advocate for it, what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding and with the right level of advocacy. We're also providing NDIS specialist nursing assessments done by critical care nurses with a legal nurse consulting background. And if you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic, and high-performing team of critical care nurses, we're employing hundreds of years of critical care nursing experience combined. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be absolutely delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again, and that's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency, and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building relationships with us and with our clients. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED settings, and you get the same level of care and simply more patient and family satisfaction because you also want to partner with your consumers, just like we do. And if you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next and what you think about this video. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.